All right, so I just kind of, some of you might have already read the book, but I do want to see, you know, one student said, "Oh, I didn't realize how depressing this course would be." You couldn't tell by the title. It's like crisis and trauma. So, uh, there are some difficult things to read in this textbook. So that is true. Um, and you will be working with clients who share very sad stories. Um, and our goal is to help them. Um, but what did you think? What did you think about with the book so far, the first couple chapters? Any comments? Go ahead.
I started finding myself like taking a piece of was like almost clear highlight tabs, and I'm starting to like take highlight sections of that I like of pieces that I think are good advice.
Yeah. Yeah, I mean I underline a lot. I mean, I always write in my books and highlight stuff or underline. Yeah. That is a problem, highlighting too much. Yeah. What do you think?
I'm so happy with modern medicine's ideas on care compared to the stuff that was described like back when he was doing stuff with the Vietnam veterans and everything, like what
Oh,
they were
yeah.
going through, like where they were compared to where we are now. It's just that was a little happy in the big depressing sphere of things.
So in case you didn't hear the comment, he's very happy that, you know, compared to the 1950s, we have such advances in medication and treatment and things like that. And I totally agree. And since you brought it up, I might as well talk a little bit about that. The interesting thing with psychiatric medication is that it is still in its infancy. We're just getting started with that. And it has helped a lot of people, but sometimes we don't even know how it works, but it does. And, that's fantastic. Um, and so technically, like, we are on our third, moving into our fourth generation of psychiatric medication. So some people would say the first one was everything included with like trazodone was a real early medication, lithium, things like that. Uh, but then came kind of all the SSRIs and then the SNRIs, and now we're moving into some really specialized medications. There is genetic testing to figure out which of the current meds might work best for an individual. Um, so, you know, we are moving along in a positive direction, I think.
No
I,
more electroshock.
what's that?
No more electroshock.
Oh, are you kidding me?
Are they still doing it?
Oh, so he said no more ECT. So it's not called electroshock, it's electroconvulsive therapy, ECT. And so here's the thing. That used to be very primitive. Uh, you know, the the shock that was used, the amount of electricity was far too high. It was not pinpointed, it was took over a vast area of the brain. Um, but that has seen great advances. And and a lot of times, so very few hospitals do it, but the hospital I work at does. And you have to be trained as a psychiatrist specifically for ECT. But it's not painful anymore. It's very localized and specific. Um, they still use it as a last resort, so they try medication first. But I've honestly seen it work miracles.
in the book when he describes it, New York took the Catholic hospital.
Yeah.
It was like he would have a conversation with them, they'd be like, wow, maybe I don't need this, and then they'd forget the next day because of the electric.
So, yeah, so when ECT was broader and more powerful, it affected memory to a greater degree. And most of the patients that I talk with now do not have significant memory loss, but it's always a possible side effect. And it's not so much, it doesn't so much happen with a treatment, it's the number of treatments needed. And now I look at an individual's quality of life, and would their quality of life be better without taking the chance than taking the chance on the possibility of, you know, a better life, basically. Yeah, so I saw somebody raise their hand online.
I was just gonna like concur with you about it. It like basically like I don't know, just helping certain clients out a lot. When I was working at a psych hospital, we had one older woman and she was pretty much completely catatonic when she came to us. And then after some treatments, she was like talking, laughing, playing games, coloring, like way different than when she came in and we could like we had to feed her essentially. So yeah, I think like in that case, it she was older and um it was better to like not have her be catatonic than like risk. Like it was worth the risk in that situation, I feel like.
Absolutely. And that's a perfect example. I've seen that myself many times. And, you know, I think in the past, maybe, they might have thought it was a form of dementia or something like that. Um, but yeah, I've seen really positive things. Absolutely. Yeah. Okay. Any other questions or comments about the book or your readings? All right. Um, so honestly, this is only the second time I've taught this class. Um, and mainly the way I teach classes is, um, you know, if we're using a book like The Body Keeps the Score, a lot of times I do use books like for my grief and loss, I use Tuesdays with Morrie, or you know, I try to use actual readings from sources in most of my classes. And yeah, so I've made comments throughout the text, and they remind me of stories from patients. And so, I kind of I give you my point of view. I explain a little more in depth about what you might be talking about, or tell you stories about patients as examples. Um, and you're reading The Body Keeps the Score, but I'm also going to supplement it with some things from another textbook, and that'll just be in lecture format. And then you've got all the links in future weeks, and you can read that stuff online, like the ACEs handbook and things like that. But we'll talk about that too. You won't be on your own with that. We'll talk about it. Like, I don't really like classes that just have you read and do a discussion board. Like, even if it's totally asynchronous, I think you should have a lecture. I mean, what are they paying me for? So yeah. All right. And I think it is like I'm almost 59 years old. And so I can remember, a lot of the stuff that he's talking about from years gone by. And so all of the older psychologists um, and, uh, and counselors, uh, we kind of refer to when we started by the color of the DSM. And and the two earliest colors were brown and gold. And then there was like um green, maroon, blue, silver, um what is it, purple now? Yeah. And so yeah, so you kind of know when somebody started by you say, "Oh, what was the color of the DSM you first used?" So it is kind of interesting. Um, so sometimes I do underline quotes that I like, and then we can talk about them. And I think this is so true. Trauma, by definition, is unbearable and intolerable. Most rape victims, combat soldiers, and children who have been molested become so upset when they think about what they experienced that they try to push it out of their minds, trying to act as if nothing happened and move on. It takes tremendous energy to keep functioning while carrying the memory of terror and the shame of utter weakness and vulnerability. And you know, I think as we move forward in the readings, we're going to talk about, how trauma stays with us and uh, the way we perceive trauma. So, for instance, individuals perceive trauma when they think about it as if it's happening now. And that's why it creates panic attacks and all kinds of, other symptomology. Uh, and it's because our brains were not able to process the trauma in the same way as something else that might not be traumatic. And we're going to talk about, how that's processed and how we're stuck in fight, flight mode, fight, flight, freeze. And, you know, we're going to talk about uh, why, the amygdala doesn't shut off the same way, and, cerebral spinal fluid and how that doesn't, wash through the brain after trauma. So there's a lot of reasons for this, but the perception of trauma is different than other non-traumatic memories. Um, and you know, I think that one of the interesting things that this book brought up, which is a new theory, uh, by the writers of this book. And it says there are fundamentally three avenues. Um, it says the vast increase in our knowledge about the basic processes that underlie trauma has also opened up new possibilities to palliate or even reverse the damage. We can now develop methods and experiences that utilize the brain's own natural neuroplasticity to help survivors feel fully alive in the present and move on with their lives. And so these three avenues, we're going to talk about each one. One is top down, by talking and reconnecting with others and allowing ourselves to know and understand what's going on with us and processing the memories of trauma. So that was the original way, let's process this trauma. That's what most therapists used to do. The second way, by taking medications that shut down inappropriate alarm reactions by utilizing other technologies that change the way the brain organizes information. So I would say, my view of medication is that I try to limit medication if possible. I try counseling first and, other interventions. But if medication is needed, yeah, then I'm all for it, you know? I just don't like over medication or, um, you know, in two senses. First, in society, like maybe there's too much medication overall in American society of all kinds, or an individual might be prescribed either higher dosages than needed or multiple medications because all of the different physicians don't communicate with one another. So, on a number of levels, but, you know, so, you know, I kind of take both viewpoints that, yeah, medication's wonderful when it's needed, but sometimes both quantitatively on a societal level and individually, sometimes there's over medication. And so, one of the things that I like when I was a private practitioner, if I saw side effects, so for instance, like a child might have tics, and I knew that was a side effect of over medication and the dosage of whatever they were taking was too high. And so it could become a permanent physical symptom and side effect if not recognized. And so one of the things, if a child had uh, been dealing with an issue for many years, and they've tried many different medications or they've added medications. Sometimes they would add medications to treat side effects. Um, I would try to get them, and I knew which hospitals did this. So when I was in Central PA, I would send them to Hershey Medical Center. Um, and what they would do is they would find a new baseline. And what that means is the child would stay inpatient and they would, gradually remove the medications they were on. And then um, they would examine and reassess basically to figure out where is this child without any medication so that they would have like a clean slate from which to work. And then they would, you know, move from that point forward. Um, I think that, um, the book cites some studies where, uh, medication, works better than top-down therapy. However, newer studies show that a combination of medicine and therapy works by far the best. Medication can treat symptomology, but so far, medication is not a cure. And that means it's not like if I had a bacterial infection and I took an antibiotic, it would cure me because I would only take that medication for so long and then I could stop and the symptoms would not return of the bacterial infection. So that is technically a cure. However, so far, psychiatric medications are not a cure because you have to remain on those medications. They're a significant help, and I'm all for them. But I would say that there's a difference between a medicine that would be a cure and a medicine that would ease symptomology. And that's why I like the combination of therapy and medication. Um, the third thing, the third avenue, I think, is the most modern, and what I have come to support, and it's called bottom up. So rather than top down, and allowing the body to have experiences that deeply and viscerally contradict the helplessness, rage, or collapse that result from trauma. Um, so, and that's where he really starts talking about what this title is about. The Body Keeps the Score, Brain, Mind, and Body in the Healing of Trauma. Now, the thing about this book, and I want to kind of warn you, is that the first half of the book is really difficult to get through because it talks about the brain, and some of it's pretty complicated. I had to read some of it a couple times to get it. But the second half is all about the most advanced treatments. And that's the best part, I think. I think the first half is really important because it gives you an understanding of trauma and how it affects us. And it looks at it from a new perspective that wasn't used before. And so I think it's great. But I like the second half because all the chapters are about treatments, and so I most people like the second half better, but so the first chapter is all about when he worked with veterans, and I really related to this chapter because my dad was a veteran. I might have told you a story about that, and how the diagnosis of PTSD, what was it, 1980 or something like that, that they came out with that. So I was already, in the 80s, I was headed to college, and it's hard to believe how recent that diagnosis of PTSD came out. Um, but with that, you know, uh, a lot of new treatments and medications came out. One of the medications, I don't know if they mentioned it or not. I know they mentioned the early medications. Then they mentioned some of the early tranquilizers, and they mentioned the SSRIs and other meds. But I don't know if they mentioned the use of beta blockers. That's become the number one uh, med at the VAs for military who have suffered PTSD. Um, and it goes about treatment in a different way. So rather than affecting serotonin and dopamine in the mind, what it does, so let's say we either raise or lower serotonin and dopamine, and that eventually affects the rest of our physical body. So it could prevent a panic attack or something like that. But it goes about it the opposite way. So like a beta blocker like propranolol, which was one of the earlier ones, it actually regulates the heartbeat. Okay, so if you think about PTSD that could lead to panic attacks and anxiety, the first thing that happens physically is usually our heart begins to race. And if we can regulate that with a beta blocker, it's not as intense. And then our mind doesn't respond to our physical body in the same way. So it kind of reacts in a little different way. But yeah, so he was first working with Vietnam vets, and when I started thinking about this, and I worked with a lot of veterans through the Red Cross, and Reconnections. But one of the things, and something interesting, it wasn't that long ago that the VA approved LPCs, to work as therapists in the VA. So we can now, you know, and not only can we work with the Veterans Administration, but we can also sign off on the military insurance, which is TRICARE insurance, once we get our LPCs. So working in a VA and signing off on TRICARE insurance kind of goes hand in hand, and we can do that now. So one of the things that is interesting is that I personally think that part of the trauma in military deployment is not only an individual experiencing a traumatic event, like a near-death experience, but it's also the loss of, their friends and comrades in those situations. So I think, it's a combination of, PTSD, but also grief and loss that is complicated grief and loss. And he doesn't really get into a lot of grief and loss. He did tell a story about why one of the his patients at the VA had nightmares and wouldn't take medication that treated the nightmares. And when asked why, he said, well, even though it's a nightmare, it's keeping the memory of my friend alive. And, I would call that complicated grieving, because I would say there are other ways to keep that memory alive, So one of the theories I developed it's called regret therapy. And me and a friend of mine, Adrian Tomer, is a developmental psychologist, came up with regret therapy. We talk about regret therapy if you ever take the grief and loss class. But let me just use his example here from the book. And so if you used a combination of treating PTSD and treating complicated grief using regret therapy, the grief part alone might look something like, okay, well, let's do a role play. And, I want you to imagine that, I am your friend who, you lost in that conflict. What would you say to them? And a lot of times there is kind of like survivor's guilt. There is, I wish I could have saved them in some way. There are all kinds of regrets. And my theory is 3 kinds of regrets. There's 2 types of past regret. The first past regret is regrets of omission, things that we didn't do that we wish we had. Maybe we wish we would have said we love someone more or spent more time with them. Maybe we wished we had saved them in some way or acted differently. The second type of regret is a regret of commission. We committed something, we did something that we wish we hadn't. Well, I wish I hadn't have argued with my partner before they were in the car accident. Or I wish I, hadn't misbehaved and then something happened to my parent or guardian. Or, whatever it might be. It's some form of regret about something we did that we wish we hadn't. And then there's future-related regret. We all have kind of a plan for the future, and our loved ones are usually in that future. But if something traumatic happens and they're no longer in that future, our future plans need to change. And our relationship with that other individual changes. I don't think the relationship stops. just because somebody dies. I think the relationship continues because they're part of us. But so imagine doing a role play, you know, and the surviving patient can express those guilts, those regrets to their friend who died. And then we get up and we change places in the role play and say, okay, you know your friend better than anybody. So you know how they would respond. It's just never been verbalized. So picture me now, I'm you, you're your friend. What would your friend say to you after you express those regrets? And the friend would most likely say, ah, you know, I don't even need to forgive you. That's just what happened, you know? And you know we cared about each other, you know? We were best friends, you know? Or, you know, we loved each other or whatever the relationship was. And you know, and then I say, you know, ask your friend, you know, what would they like you to do with your life now? Would they like you to keep dreaming? And, you know, so they go through the role play again. And of course, the friend's going to say, I just want you to have a happy life. That's what a friend would say. So there are some caveats, you know. I would make sure that it was a loving relationship, that they did care about each other. I'm not going to have them do this with an abusive relationship. Um, you know, so I'm going to check out what kind of relationship it was before I throw them into a role play like this, you know. If there were abuse issues between partners or parents or something like that, then I wouldn't do it. I'd do something totally different. Um, so I do think that, you know, a lot of times, especially with veterans, but not only veterans, people who have experienced traumatic events where there's been, uh, you know, a life or more than one lost. Um, you know, I think grief and loss is an important component of that, in addition to treating the PTSD. Um, so he, in this very first chapter, he talks about that, you know, our entire body responds to trauma. It's not just in our minds, but you know, uh, I think that one of the things I underlined was the greatest sources of our suffering are the lies that we tell ourselves. Working at the VA, I soon discovered how excruciating it can be to face reality. This was true both for patients and himself as a therapist. We don't really want to know what soldiers go through in combat. We do not really want to know how many children are being molested and abused in our society, or how many couples, almost a third of all couples, as it turns out, engage in violence at some point during their relationship. It's almost like, you know, we used to watch these commercials about starving children or, you know, donate to this cause or donate to that cause. And um, I did donate to one of those, and I guess it was called like Sponsor a Child, you know. And you know, a lot of times people make excuses and they say, oh, they're just ripping you off. Why do you do that? You know. And then one time I went on a mission program, I guess it was in Peru, and I visited one of those organizations, and it was like an orphanage and a school and treated a whole area, you know. And they did wonderful things. And so, you know, these things reaffirm my faith in humanity sometimes. And but uh, it is difficult to think about all the human suffering and and how much there is in various societies, including our own society. Um, there's a section called Trauma and the Loss of Self. And, I think the key points that stood out to me, and maybe you have different ones that you can write about, uh, is numbness or rage. And without maybe a middle ground, you know? Um, so when I begin to think about the way they describe these symptoms, um, it goes all the way back to kind of Bowen and so Murray Bowen and, um, family systems and all kinds of things. But, there is a reason why we numb not only our emotional pain, but it turns out we numb our physical experience as well. We are no longer in touch with our bodies in the same way. It also talks about reorganization of perception, like hallucinations or, um, you know, uh, other types of experiences. Um, he wrote The Five Men Who Saw, so ink blots. So this is kind of interesting because, um, a lot of people think like the Rorschach tests are old fashioned, but I gained a new appreciation of them when I was doing um, child therapy. And so, ink blots and the training for ink blots are a little expensive. So uh, I had a whole expressive arts room, a play therapy room, and so um, one of the things they could do is they could paint or they could draw or color, or they could do play therapy. We had a sand table, we had all kinds of dress up things. Um, but uh, I started making our own ink blots. I would fold a piece of paper in half, and we would start with like black ink and put a drop on the paper, and they could like drop it any way they want. Then we'd fold it and smooth it out and open it up, and it would look like a Rorschach ink blot. That's how they made them. And they could say anything they wanted about them. And and eventually they were able to use colors as well. And one of the interesting things that the book said was that um, trauma affects the imagination. Five men who saw nothing in the blots had lost the capacity to let their minds play. But so too had the other 16 men, for in viewing scenes from the past in those blots, they were not displaying the mental flexibility that is the hallmark of imagination. They simply kept replaying an old reel. So people can see trauma or nothing. It's almost like trauma or nothing. There's no middle ground of imaginative play. The other interesting thing I read was that, um, the first few blots are black and white ink, but after that, they add some colored in, and the color can bring out a more emotional reaction or memory to the ink blot. And you know, I think it is interesting. Um, they had a section called Stuck in Trauma. Somehow the very event that caused them so much pain had also become their sole source of meaning. They felt fully alive only when they were revisiting their traumatic past. And we're going to talk about why that is. And it's really about the amygdala, the way the brain stores those memories, and why it keeps replaying almost as if it's in the present instead of something in the past that can no longer harm us. One interesting thing is the diagnosing of PTSD. So I found a lot of misdiagnoses. If you look at the symptomology of PTSD, a lot of the symptomology and the criteria under PTSD are very similar to other diagnoses. So, for instance, I've seen misdiagnoses for bipolar, or depression or anxiety, uh, all kind ADHD, all kinds of other diagnoses because the criteria and symptomology under PTSD often mimic those other diagnoses, but the root cause is so often trauma. So I always explore that possibility before making one of the other diagnoses. Let's see. Yeah. Anybody have any comments on that first chapter or questions about anything? I'm just highlighting the stuff that I feel a need to talk about, but you might pick up on something that I didn't mention, and you can write about that in your discussion boards. All right, yeah.
Chapter 1.
Wait till you read the brain.
Chapter, do you know why shock tests cause like such greater results?
I haven't read why. That switch from kind of the black and white ink to the colored ink would have that emotional reaction, but
The first one just be like, that's being gloss. The second one, color, and they're like, that's my disembowelment.
yeah. I don't know the reason for that. Yeah. But it is interesting. I haven't noticed, well, I mean, so I have seen different reactions to specific colors that are related to things in the trauma that they experienced. So, like, what color do you think would get a big red? Yeah.
And isn't it like, I don't know if it's more related to like business psychology. I have a friend that was going through that. She's like was excited about like color theory or something like that in relation to psychology and how
There is a lot of color theory in psychology, like they find colors that calm us or make us hungry. So light blue or light green calm us. So a lot of things are, hospitals are painted those colors, or orange makes us hungry. Um, yeah, so Emily posted something I'm just blowing up. Yeah, so yeah, how PTSD and trauma and ADHD, and there's an overlap, and yeah, all kinds of things. Yeah, thanks. All right. So I think there's a difference between matching symptomology and overlapping symptomology. Okay, overlapping symptomology means that, so let's use PTSD and ADHD. It means you have ADHD and you suffer from PTSD. And part of the symptomology overlaps. But I guess I was referring to symptomology and criteria that appear in both, and um, you might only have a PTSD diagnosis, but you might display some similar symptomology as ADHD. So you get a misdiagnosis. It's slightly different. Yeah. But both are possible for sure. Both are possible. Yeah. All right. Let's see. Uh yeah, so chapter 2, it kind of walks us through kind of a little bit of the history about psychiatric medication. So, Thorazine was a very early medication. Some of the earliest medications were tranquilizers, you can understand why. Um, and you know, but I think that you know, uh, there's a lot of comments here that speak therapeutically to humaneness, you know? And so for instance, like I like what he said about um let's see what it was. Um like I wouldn't do anything to a patient or a client that I wouldn't do to somebody I loved personally, like a family member, you know? And I think that makes a lot of sense. Like when I had to go through like training to restrain people, I'm thinking, I don't know whether I'd really like to do this or not, you know? And so I only restrained one child in my entire career, and that's because they were trying to harm themselves. They were banging their head against a concrete wall, and it was gonna cause some physical damage. So I gently restrained them until they could get some help. And you know, um, and adults, you know, I think I think this is one area where we really have advanced. Um, I think one of the problems in our society is like anybody in the mental health system understands proper restraining and when to use it, and um, you know, uh, how to treat individuals with, you know, kindness and respect and uh, gentleness as much as we possibly can. Um, the problem is other I don't know, disciplines or uh, what do you call it? So, police and other professions are not trained in this. And so, for instance, me and a group of students went down to Belize to train the police academy in appropriate de-escalation and how to deal with somebody who wants to commit suicide with suicidal ideation, how to do a mental status exam and things like that. And a couple of my students just got jobs. Yeah, it's hard to believe that, Belize is training their police. This is like 2 days training seminar at the Belize Police Academy. All of our police officers should know this. One thing that some areas are doing, West Virginia is doing it right now. They are hiring, mental health professionals to ride along with police officers on calls for, somebody with a mental health issue. Um, I know that I've had many clients that, you know, if I had been there, they'd probably be alive today. So, uh, you know, I think that's one thing that's important, you know, humaneness, and misunderstanding uh, somebody with mental health issues. I underlined, Semrad taught us that most human suffering is related to love and loss, and that the job of therapists is to help people acknowledge, experience, and bear the reality of life with all its pleasures and heartbreaks. The greatest sources of our suffering are the lies we tell ourselves. He'd say, urging us to be honest with ourselves about every facet of our experience. He often said that people can never get better without knowing what they know and feeling what they feel. So, and then he goes on to talk about, you know, the advancement of medications and, you know, um, so like antipsychotic drugs were a major factor in reducing the number of people living in mental hospitals in the United States from over 500,000 in 1955 to fewer than 100,000 in 1996. For people today who did not know the world before the advent of those treatments, the change is almost unimaginable. I don't know if that's all positive. So, yes, antipsychotics, and we still don't know exactly how they work, but yes, antipsychotics really help people suffering from schizophrenia or other types of psychosis, and it could help them to lead a much better life and possibly gain independence. But think about how many of our homeless individuals suffer from schizophrenia or post-traumatic stress disorder. How many of them are veterans? One interesting thing is that there is an overlap between veterans and not only PTSD, but veterans and schizophrenia. There's a reason for that. It's not that the military causes schizophrenia, but if somebody is genetically predisposed for the possibility of suffering from schizophrenia, one of the things that can trigger schizophrenia is extreme stress or trauma. And so, the onset of the majority uh, who experience schizophrenia is between 18 years old and 24. So when you think, when is somebody going to join the military? 18 years old. They're going to experience boot camp. They're going to experience training. They might experience deployment. And so the military is one of the extreme stressors that an individual can experience at that age between 18 and 24. And so if somebody is predisposed to schizophrenia, that could trigger it. And that's why you have that overlap. Um, you know, uh, or if they experience, deployment and combat. Um, so, you know, um, I think that um, one of the interesting things he talks about is repeating trauma. That, and we're going to talk about in later chapters why people experience multiple traumas. And, I think that is an important topic. I think the only other thing I want to talk about from this book is, you know, the high occurrence of suicide, in veterans, and that has gotten worse over time. And right now we have the highest number of suicides with veterans ever in history. I think that a lot of people misunderstand suicide in that, they think people no longer want to live. But I have not found that to be true. I found that suicidal ideation is really just a desire to escape the um, the suffering of emotional trauma and illness. And they've tried every other avenue, including medications or self-medication or treatment. And they feel as though there's no other way to escape that suffering. So, it's a little different way of looking at suicidal ideation, I think. Okay, so it is 8:12. We're going to take a 10-minute break. It's 6:12. Sorry about that. 6:12. We're going to take a 10-minute break. Then I'm just going to follow up with some supplemental information from other sources other than The Body Keeps the Score. We'll be like another half hour after our break. So yeah, 10 minutes, come back at 22 after or so.